This is the Emergency Medical Minute. Real, raw, relevant emergency medical education. Please enjoy the show.
Hi listeners, this is Rachel Duncan. I'm here with my co-chair Jack for the Emergency Medical Minute, and today we are talking about sepsis care with Dr. Susan Brion. And Susan works in the Swedish Medical Center ER and is the Associate ER Medical Director and works with the CarePoint Physician Group. She is one of our ER representatives on the hospital-wide Sepsis Committee. And Susan, do you just want to talk about how you got involved with the Sepsis Committee and what that committee is comprised of and who you're collaborating with?
So when I became the Associate Medical Director, I assumed the role of the ED liaison to the Sepsis Committee here at Swedish, which is comprised of myself as the ED physician liaison, but also ED nursing, as well as ICU intensivists, ICU nurses, and the hospitalist service as well. We also have the sepsis coordinator who runs these meetings, and the basic premise for these meetings is to provide collaborative care using best practice for sepsis within the hospital.
Is any part of this committee work also looking at metrics to measure how we're doing?
So that is a large part of the committee work, not only to look at our own metrics, but our metrics across the nation and in comparison to other HCA hospitals, but also nationwide as well. And at Swedish, we also do very well with our management of sepsis, both within the HCA and within the nation.
Can you give us an example of some of those metrics that we would be tracking for individual patient cases to sort of tell us how we're doing and where we can improve?
The main metrics that we look at are sepsis and septic shock mortality, and those are the things that we try to track over time.
Susan, can you talk to us a little bit about the history of sepsis and where this campaign called Surviving Sepsis came from?
So in 1999, the American College of Chest Physicians and the Society for Critical Care Medicine came up with guidelines that optimize the hemodynamics of patients with sepsis and septic shock. And a doctor named Emmanuel Rivers used that as a backdrop to direct resuscitative efforts at kind of the most proximal part of a patient's care within the ED, and thought that he could maximally improve their morbidity and mortality by starting this resuscitative efforts here in the ED. And that was the birth of early goal-directed therapy. So that came out in 2001. And what EGDT did was it screened patients based on at least two SIRS criteria: evidence of hypotension and hypoperfusion as evidenced by an elevated lactate, and suspicion of infection. And EGDT was the first emergency department-based randomized controlled clinical trial to demonstrate a significant impact on mortality in patients with sepsis and septic shock. And so EGDT pointed out that sepsis was no longer an ICU disease, and it made people aware that the key to successful management of this life-threatening disease was early recognition. And it also recognized emergency physicians as resuscitation experts, and that they have the ability to recognize this disease early on. So then ACEP and the Society for Critical Care Medicine went on to fully embrace EGDT and the impact that it had on the delivery of care with patients with sepsis, and developed the Surviving Sepsis campaign in 2002 and the resulting guidelines that came from that. There are several campaign goals, not just guidelines, that they promote. It's a building an awareness of sepsis. They want to improve diagnosis. They want to educate healthcare professionals and implement a performance improvement program as well. And so that's basically the start of the Surviving Sepsis campaign. Since 2002, it's had several revisions of the guidelines, and most recently in 2016, the new guidelines came out.
Can you talk to us a little bit about the 2016 update and what Colorado ASEP has really done to change their recommendations for ER physicians, how to change their practice to be in alignment with those guidelines versus maybe some things coming out from CMS and other organizations?
So I think it'd probably be best to start with what is the difference between CMS guidelines versus the Surviving Sepsis campaign. And of note, ASEP fully supports the Surviving Sepsis guidelines. The CMS guidelines are more established definitions of sepsis that have been established over the years. Importantly, they look at 3 categories of sepsis. They look at sepsis, severe sepsis, and septic shock. CMS defines sepsis as SIRS criteria plus evidence of infection or suspected infection. Then severe sepsis is sepsis plus evidence of organ dysfunction, and that can be either several different parameters or just an elevated lactate above 2. And then septic shock is sepsis plus refractory hypotension plus or minus lactate. And those would be the CMS definitions. Now, the Surviving Sepsis campaign interestingly, has taken out the severe sepsis category and just looks at sepsis versus septic shock, which I think goes along with a lot of our previous training in sepsis and seems to inherently make more sense. So they define sepsis as the CMS definition of severe sepsis, which is sepsis plus end organ dysfunction, so sepsis plus an elevated lactate. And then septic shock, again, is just refractory hypotension plus or minus an elevated lactate. So that being said, those are kind of the two major categories. Just to make things even more confusing, there's also a Sepsis 3 guidelines that just came out in 2016, and that was from the International Consensus Definitions for Septic and Septic Shock. And I won't go into that very much because it's really hasn't been well accepted and not endorsed by ASEP. But looks at something called the Q-SOFA score, which is the quick SOFA score, but we're not actually using that at this time, and there has not been good enough evidence to support the Sepsis 3 guidelines.
So here, lactate, I feel like, has become very important. It's something that we really do up front that maybe a few years ago was not as important in identifying these patients. Would you agree?
Absolutely. So one of the things that's new in the Surviving Sepsis guidelines is that the normalization of lactate and actually using lactate to guide your resuscitation efforts. So checking it initially and then making sure that it's rechecked within 6 hours. Here in the emergency department, we try to do that even faster within 2 hours to see if the lactate is going in the right direction. Now, keep in mind that lactate is not a direct indicator of tissue perfusion, and then there's many other things that can cause an elevated lactate, and that if you use lactate alone in guidance of resuscitative efforts, it has not been shown to have any mortality benefit. So it's one part of the bundle that we use, but it's definitely a very important part.
Can you talk about other aspects of the bundle that are included here in your practice and that you've made sure are included at Swedish to really bring the best patient outcomes possible?
So first and foremost would be IV fluid administration, and getting that on board early, particularly in patients who are hypotensive. The 30 cc's per kilogram bolus is important and a critical part of the Surviving Sepsis guidelines and CMS guidelines. Once we give the fluids, it's very important to reassess and check a patient's fluid responsiveness. And that's something that is changing and kind of growing within the emergency department as we speak. And using a dynamic indicator of fluid responsiveness versus a static indicator. So by static, I mean like CVP used to be recommended in early goal-directed therapies, and that's kind of gone by the wayside. Now we're looking at things like stroke volume changes. We're looking with passive leg raise, bedside ultrasound I use quite frequently to assess IVC collapse with respiration and kind of give an idea of volemic status in patients. But looking at things more in real-time hemodynamics. And then after you reassess, and of course you also want to give early IV antibiotics. And sepsis guidelines, surviving sepsis guidelines recommend within an hour for both sepsis and septic shock. The evidence for that is not great, but there is good evidence that shows that every hour of delay in antibiotics has a significant link in mortality.
Yeah, and with the time to, antibiotic, I would add time to appropriate antibiotic
Exactly.
is very linked in studies, and that's an emphasis that I think some folks forget about.
Exactly.
So really, when you think about a patient, are you taking into account things like source and where they came from to guide your antibiotic therapy, or would you say everybody just needs broad spectrum immediately? What's your feeling on that?
So I would say absolutely not. Not everyone needs broad spectrum immediately, and we should be trying to take in source with every single patient and individualize as much as possible. That was another change with the Surviving Sepsis campaign, was to try to actually decrease the use of combination therapy, antibiotics in patients that don't need it, and having more monotherapy as indicated.
Beyond early goal-directed therapy fluids and appropriate antibiotics, so you get further down the algorithm, what are some of the other points of care that have maybe changed that you've seen change over the years on their recommendations? So for example, recommendation for Pressor therapy. Have you seen any changes in that over the past 10 years?
So I would say that the recommendations for Pressor therapy have, in terms of the actual agent, have remained fairly the same. However, it's deciding when to use pressors that has changed. So in using more dynamic indicators for fluid responsiveness, deciding whether a patient needs more fluids after that 30 cc per kilo bolus versus a vasopressor is, I think, what has changed. Some patients will need more fluids, and it's better to try to determine that before starting a pressor immediately, which was the way that it was before. We've kind of gone from this quantitative, static resuscitation to a more patient-centered, hemodynamic assessment of patients. And then if you do decide that you need pressors in your patient, norepinephrine remains the first-line agent, followed by vasopressin plus or minus epi as needed. And then if you need an ionotrope, if you're having some low cardiac output, dobutamine versus epi can be considered as well.
You talked about sepsis bundle, and I feel like we've kind of gone through that and explained it. What are your feelings on making sure that the sepsis bundle is provided in an easy toolkit for providers? Do you believe in using order sets up front to really guide this type of therapy? And what's the recommendations that we're receiving from our different guideline committees?
So I personally believe that the order sets are the best way to accomplish these bundles in a timely fashion. That's, I think, what has given us the most success here at Swedish as well with our sepsis protocols here is the use of order sets. I haven't seen a lot of literature representation of what would be best in terms of order sets versus not, but I think just in my own experience here at Swedish that they're necessary to accomplish all of the things that you want to up front and early on with patients.
Can you talk to us a little bit about the term sepsis alert and what that means, and exactly who that pulls into the situation and how you see that maybe either benefiting or not outcomes?
So the idea of a sepsis alert is based on the idea of cardiac alerts and stroke alerts and the other programs that we have in place here that we do so well with in identifying patients that are critical. And bringing sepsis to the forefront of everyone's minds as a critical patient in which we need to act fast and accomplish all of these things within the bundle. So the idea of the sepsis alert, I think, was one that came out of the Sepsis Committee to try to identify patients early and quickly based on SIRS criteria and suspected infection.
Susan, talking about some of these therapies that are really well established and haven't changed over the years. So the early goal-directed therapy, antibiotics, lactates, things like that. What are some other therapies in the continuum of care of sepsis as the patient goes throughout their ED stay into the inpatient side that maybe have changed over the years? You know, what has risen and fallen and what is still kind of stuck?
There has been some definite changes in early goal-directed therapy. It is not uniformly recommended anymore, and that's particularly with the concepts of requirements for CVP and hematocrit and central venous oxygenation. None of those are recommended anymore, but the central aspects of sepsis care have remained the same and are a bit clearer, which is just early administration of IV fluids, appropriate administration of IV fluids, so higher 30 mils per kg, and then antibiotics within the first hour, and then following lactate clearance. I would say those are three of the mainstays of sepsis care that have not really changed and have just been refined. The additional therapies and some of the other things that have been tossed about with sepsis care, such as glucocorticoids, steroids really are not indicated unless you have refractory hypotension to fluids and pressors. It's kind of an additional thing you can have in your toolbox if you think it might be indicated, but definitely not something to use right off the bat. The inotropic therapy really you want to consider in patients that are hypotensive but have any type of cardiac history that could be also contributing to that. It's always hard to get that heart failure patient who's also septic. Kind of the role of procalcitonin has been discussed a bit as well. Really in the emergency setting, it can be drawn and measured to help our intensivist and hospital colleagues kind of follow whether or not they can de-escalate their antibiotic use to see if this really is infectious versus non-infectious source, and try to help reduce length of stay within the hospital by using that as a measurement. There was a recent article that was published in June with the American Journal of Respiratory and Critical Care Medicine, and it looked at the implementation of the sepsis bundle for patients with sepsis and intermediate lactate values. So for those lactates between 2 and 4, those are the patients that have the highest potential, I think, to decline if we're not aggressive enough. But then you have a subset of patients, those with chronic kidney disease and patients with chronic heart failure, that you're just not sure how much fluids to give. And that's, again, where the dynamic measurement of their volume status is important. But in this study, they actually used the full 30 cc's per kilos in those patients. They got quite a bit more fluids than had been given before, and they looked particularly at those patients, and their mortality was lower than the other patients. So just keeping in mind maybe perhaps that they are still volume depleted, and that fluids can be of significant benefit in those populations.
So a lot of these other therapies and gray areas, I feel like I've been moving targets within the sepsis care over the years. What would you say to providers that are not adapters or late adapters to new things coming out on the basis of it's all a moving target, it's just going to change again?
I'd say if you look at the history of sepsis, that, as I mentioned before, hasn't changed that much. The basics of sepsis care have remained the same, and if we provide consistent care, then I think that's what's going to benefit our patients the most. And by consistent care, I mean, using the order sets, trying to make sure that we are in compliance with these bundles, which have been studied extensively and have been shown to be of significant mortality benefits. So for those kind of late adapters, it is a moving target, but it's one that we're continually honing in on and making it easier for us to take care of our patients.
So have we seen strides in sepsis care from 20 years ago to today? Has morbidity and mortality gotten better? I mean, it's a really high mortality group, right?
It still is a very high mortality. I've seen anywhere from 10% in severe sepsis to 20 to 30% in septic shock. Here at Swedish, we've made significant strides
We are shooting for a less than 15% mortality, and we're working towards that goal. And just in the time that I've been involved with the Sepsis Committee here, we've made significant improvements in morbidity and mortality.
And what specific interventions have you worked on with the committee in your years of work with them that have reflected to outcome changes?
I would say the early fluid administration, so including EMS administration of fluids into our calculations, as well as point-of-care lactates. I think that has made a tremendous impact in our care of sepsis patients.
So Susan, we've had this great discussion about Surviving Sepsis campaign, CMS guidelines, Colorado ASAP giving guidelines, and automating all of these things into order sets and sepsis alerts. Is that all there is to it? Is there still room for your clinical judgment each day with patients? How do you sort of balance those two things? And is there a place for both of them?
So absolutely, I think that clinical judgment still needs to be at the top of any sepsis patient's care. You have all of these tools available to you, and that's exactly what they are tools to help you in the care of this patient and to guide you in the care of this patient. However, patient care needs to remain individualized. You still need to use your clinical judgment and acumen to the best of your ability to individualize therapy for patients. Following protocols is helpful in timeliness of interventions, but also remembering that each patient is different and may need different interventions as well. I think we all know that. It's going to continue to be a moving target in terms of finding that balance between following our guidelines and our protocols and also following our own judgment.
So it sounds to me like you definitely think that there's room and benefit to both of those aspects.
Absolutely.
Well, Susan, we certainly appreciate you chatting with us today and enlightening all of us on the history of sepsis, various guidelines that have come out, how you've balanced that in your current practice with your clinical judgment, and just this moving target of sepsis. So thank you so much for chatting.
Thank you.